Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN, Healthy World, Healthy Nation, Healthy You. I am Nancy Valentine, PhD and registered nurse, and this show is dedicated to you, the healthcare consumer. And one of our broad goals is to help you navigate the healthcare system more effectively. And our topic today is one of the most demanding areas that you will encounter potentially in how to navigate the complexity of the healthcare system. We're not shy about taking on some pretty knotty topics on this show, and I think that this one will really be a test of our ability to take something that is extremely complicated and bring it down to size for you to understand it and help you to navigate if you find yourself in this situation. So our topic today has to do with hospital admission. If you ever go to a hospital, and the title is, Am I Admitted or Not Admitted? How the term observation status is used in a healthcare setting. Now that's a mouthful right off the bat, and let me try to explain that before I introduce our very knowledgeable guest who will walk us through this process. Observation status is a term that you will rarely hear when you're in a hospital. It's that sort of behind the scenes kind of discussion that your ER doctor, emergency room doctor may be having some discussion about should you really be admitted formally to a hospital bed, or given your situation, should they just keep you and observe you for some period of time. So we'll talk about the fine points of that, but just to get through the title so you know what we're going to talk about, that is what observation status means. So you may think that you're admitted, but you may not be formally admitted, and we're going to talk about the consequences. So the 3 key points that we're going to take on in this show is to define terms: observation status, being admitted or not admitted. We're going to talk about the catch-22 that the hospitals find themselves in and how they can actually be penalized depending on the situation of how they decide whether to admit you or not admit you formally. And then our 3rd key point is to really give you some very factual steps in terms of what you can do if you find yourself in this situation, because there are clear financial repercussions, and this is really something that you need to pay attention to, because believe it or not, it happens much more frequently than you may realize. Now, hopefully you don't see the inside of a hospital, you're staying healthy, and you're really not having to confront this. But if you do, it could be something that happens as an accident, you wind up at the emergency department, or you're just going in because you're being readmitted for a condition that you've had for some time. It can be a whole range of different experiences. So we're going to talk about that and explain each one. So I'd like to introduce our guest and our expert in this area. I'd like to welcome back for another show. Linda has done some shows for us before, but Linda Rolanu is the president and CEO of her own company, Genuine Healthcare Resources. And Linda is a very experienced nurse with more than 20 years of experience. She's a clinician. She's worked clinically in a number of hospitals in the Philadelphia area. She has worked in insurance companies with health insurance, and she's worked in pharmaceutical companies. So she is very experienced. And part of her practice is what she's going to talk about today, because she gets inside the box of observation status and really helps people and guides them through some of the complexity of this. So Linda, welcome back. I'm so thrilled that you can do another show with us. You are a powerhouse of knowledge. So we're going to tap that brain of yours one more time.
Okay, well,
and help
thank
us.
you.
Well, thank you for being back. But I want to tap your expertise, because Linda was telling me that many times she gets called in her practice of advocacy services because people have found themselves really sort of dinged by this observation status. So we're going to start at the beginning of the story, and she's going to tell you about observation status and why this is even happening more frequently now than it has in the past. So Linda, let's start with that.
Okay, so you'd like for me to explain what is observation status?
Please.
Okay. Observation status occurs primarily when you or a loved one goes to the emergency room and the physicians on staff and the nurses, the team there, decide they're not quite sure if they want to send you home or not. They want to either do some more tests, they want to observe you. So what happens is many times you're taken to a hospital room, just like you would have been if you were admitted, and you're treated and you're given medications and you're having tests done. However, your status in the hospital is not an inpatient, though it may look like it. Your status is an outpatient because they're only observing you. You have not officially been admitted. And this is their ability to determine, do you need to be admitted, or can they then send you home?
Right. Okay.
So that's where observation status comes in.
Okay, so now the average person would say, why do I have to even care about this? I mean, I leave it in the hands of the staff.
Right.
They're knowledgeable. They know for my situation whether I need to be admitted or I need to be observed. Why should I even care about this?
For multiple reasons. Number one, financially, it does impact. There's a significant difference in copays. And two, in order to be able to utilize and retain your benefits. So let me explain what I mean by that. When a health insurer or even Medicare contracts with facilities, they have a contract on how much they're going to pay. There's a difference between the amount of money that they're paid when you're admitted and you're an inpatient versus how much money the insurance pays the facility when you are an outpatient. So when you're an inpatient, it's like everything being bundled together. It's very complex, but a simple way of thinking about it is the cost is all bundled together from soup to nuts, and you just pay one cost, everything is covered. And you, as the patient, have a smaller nominal copay when you leave. When you're in observation status, that's an outpatient. That's like being a la carte. And we all know when you go to the menu and you buy a la carte, it tends to cost you more. And it will also, when you leave the hospital and you're discharged under observation status, your copay now can be significantly higher. As an inpatient, your copay can be in the hundreds of dollars. As an outpatient observation status, your copay can now be in the thousands of dollars. In addition, if you were not an inpatient for 3 consecutive days and you needed to go to skilled nursing or a rehab facility, you no longer have that benefit according to Medicare. You will now have to pay for all of that fee for service.
So in order to sidestep that nightmare, it would seem that the hospitals would just automatically admit people rather than have them on this observation status. But obviously, they're not doing that, and they're not doing it more frequently. So explain to us why hospitals changed their course.
Right, exactly. Well, the idea of observation status has been around for quite some time. Back when I was in the health insurance industry is when the first idea of 23-hour observation had come up, and that was many, many years ago. If you noticed, you haven't really seen or heard a lot about observation status since then. Then all of a sudden, the last couple years, just recently, observation status has skyrocketed. So the first thing you need to do is ask yourself, what has changed over the last couple years? And what has changed is 2 things, and it's all about regulation. Number one, there are an increased number now of what's called Medicare RAC reviews. And a RAC review is a recovery audit contractors. And what that means is that an auditor goes into the hospital and can look back 3 years at all the admissions that the hospital had and decide in retrospect whether they want to take money back or not.
Based on what? Why would they take money back?
They're looking at it saying that, well, back when you were in the hospital and they admitted you, they think maybe you didn't need to be admitted. Maybe you could have just been in observation status, or you could have been an outpatient and just discharged to home. So they're sort of looking over the shoulder as an auditor saying, I don't think that inpatient stay was correct. Once again, this is 3 years out. I see it as the physicians and nurses in the hospitals are doing the best. As you're presenting to the hospital, they're looking at the symptoms, they're seeing what's happening to you, and they're making a decision in the best interest of your health. Well, now when you present to the ER, not only do they need to make decisions that are in the best interest of your health, but they have to second guess and say, 3 years from now, if I make this decision, is this auditor going to come in and pull money back? Maybe I should just observe you for a while and see if what happens there, because The RAC reviews really don't come in and take money back from an outpatient perspective, but they take a lot of money back from an inpatient perspective. And research shows that that's the number one reason is hospitals are working under the fear of having millions and millions of dollars taken back on RAC reviews.
Okay. Now that was a lesson in hospital finance and healthcare finance. So let's walk through that again so that you can understand it. When you are admitted to a hospital, or you look like you're being admitted to a hospital bed on a unit, it is a good idea to ask, am I formally admitted or am I on observation status? That alone will signal to your treatment team that you are in the know and that you have some understanding of what the consequences will be. If you're on an observation status of a day, it sounds like there aren't really large implications financially for when you are discharged. Is it more than one day or is it other days?
One day, the financial implication is less because you are there only one day. Your copay is still going to be higher. It still could be 1,000 versus maybe a couple hundred. The difficulty comes in is if you're only in there in a day, but then for some reason you need to go to a skilled nursing or a rehab. That's pretty rare usually if you're only in for a day. It's when you start getting to 2 days and more that it gets tricky.
Okay. Well, I think that that's significant. In some ways, from a consumer point of view, it doesn't seem like you really want to be on observation status at all, because a couple $100 is large enough of a copay for some people right from the get-go.
Right.
To think that that could morph in 24 hours to $1,000 would put many people right over the edge.
Exactly, because it's all according to what's being done. You might only be in there for 24 hours, but if you had tests done and you had IV medications and you had all this done, that's all being charged to you a la carte. And many of your medications aren't covered because they're considered outpatient, so you pay for those as an outpatient. So it can quickly morph in 24 hours, given what they're doing within 24 hours to a significant amount of money.
Right. But if the hospital is concerned about whether they admit you and whether that admission is going to be denied 3 years later, which, by the way, when the auditors come in, what they use to really make that determination is they look at the medical record. And as you know, most organizations are moving to the electronic medical record so that they can have everything documented. And that documentation is critical to the auditors to make that determination. More than that, I don't know the fine details. I mean, I've never met an auditor that does these reviews. I do not know exactly what else they may be looking at. But the fact that they're looking at all 3 years later and denying it is a cost to the hospital. But so it sounds like the hospital, in order to shield themselves from that and bringing people in on an observation status, is basically putting the financial burden on the patient.
Right. It is more financial burden on the patient while they're in the hospital. It's more financial burden on the patient if they do need to use their skilled nursing or rehab benefits.
Right.
But as we said before these last couple years, you didn't have this huge increase in observation status because the hospitals were doing what they felt was best for the patient. Now they're trying to figure out how to live in this new world and still stay solvent, because in the end we can't afford to have many of these hospitals closed. We depend upon them. And when you're having millions of dollars taken back on a regular basis because you're having auditors coming in doing full 3-year lookbacks and then just taking this money back from you, that's a significant that's a significant hit to any business.
Now you may be asking yourselves, why did they come up with these recovery RAC reviews to begin with? It has to do with fraud and abuse. That a lot of this was spearheaded by hospitals that did have a lot of unnecessary admissions. Otherwise, it wouldn't have gotten on the radar screen to begin with. Can you tell us, to the best of your knowledge, what your experience is with that? I mean, most times we want to think that hospitals admit for the right reasons, that they are doing the best thing for the patient. But do you feel that there was a lot of abuse from what you saw?
From what I've seen in my past, there was. I mean, there is still, a sense of fraud and abuse that's out there, and I've seen some of it and known of some of it myself just from my own health insurance managed care days. Was it every hospital? No. Is it always fraud and abuse? Is it sometimes people are making the decisions that they felt were the best. It's not as if they were really going down the path of fraud about an abuse, but they probably could have made a better judgment call. Maybe
Right.
the person didn't need to be in. So there were higher costs that were associated with that. But just like with anything in life, you need to have a balance so you don't go from one extreme now to another extreme. Because the reality is, as we all get older, Medicare individuals, and we learned this, and we had to go through these numbers back in when I was working for the health insurance company, typically use 3 to 4 times more the healthcare services. If their goal is to try to ratchet down the elderly so that they're using the same amount of services as a 20 and 30-year-old, that's very unrealistic. The elderly naturally consume more services. So some of it might not to this day be actual fraud. Some of it may just be it's an older person who fell, who has COPD, who also has Alzheimer's and diabetes, and there's a lot you have to do there.
Right.
So there's a balance, and I think we've kind of swung once again a little bit too much the other direction.
Right. So what's the healthcare community's reaction to this?
They're not happy about it at all. The physicians don't like it, the hospitalists don't like it, and they're the physicians that are actually paid for and are the ones working in the hospital. When you're in there and you're attending, or the physician that's managing your care, it's usually a hospitalist. It's someone who's employed by the hospital. If you had a primary care, if you were being treated by a cardiologist or a pulmonologist, their ability to get in there and actually manage your care has significantly been decreased because it's pretty much managed by the hospitalist. And so you have your primary physician and your primary team not happy. The hospitals themselves really aren't all that thrilled either because they're being hit so heavily with having to manage from a managed care perspective, trying to anticipate what's coming down the line. And of course the hospitals aren't thrilled because they weren't doing this 2 years before. So now they're just trying to figure out how to survive with all of these coming through. Now,
Right.
some of it's training, some of it is better documentation. I used to say myself, even today when I or one of my nurses go into the hospitals or even in assisted living or a skilled nursing and we're reading through the charts, we'll say, the documentation here could have been much better.
Right.
So little things like that could actually help.
Right. It has become more of a topic that's been in the literature. Linda was telling me that there have been articles recently in the New York Times and in the Boston Globe. There have been comments made by some astute physician observers who are in the health policy world about how detrimental this is. Yes, the balance is that there were too many admissions, especially of older people, that maybe were not necessary. But that has to be balanced with now having so many less, potentially, and this observation status, which really turns out to be a burden for the consumer and something that really is not necessary as well. So how do you think this balance is going to be achieved?
There are quite a few individuals, including the Center for Medicare Advocacy, which is out of Washington, D.C. They're a nonprofit that advocates very heavily for Medicare patients. There are quite a few organizations, physicians, trade organizations out there petitioning CMS, which is the Center for Medicare and Medicaid, under Health and Human Services, to change some of these policies. For instance, can we change the 3-day rule so that you don't have to be an inpatient for 3 days before you're covered for your skilled nursing and your rehab? Maybe you can make it where maybe the person needed to be in for 2 days or one. There's so much flexibility there. Most of us believe just taking it away altogether was very helpful. Because then you just need to learn to trust the physicians and the skilled nursing and the rehab to make the right decision for the individual. Most elderly can actually use some skilled nursing or rehab before going home if they've been in more than a day anyway. So that would be one thing. The other thing is we're talking about the fact that we believe there really needs to be a review of the recovery audit contractors piece of the legislation, because it's obviously, however it's been written, has obviously allowed for the swing to the extreme in the other direction. So though we do need RAC reviews, we need to bring them back a little bit more to the middle. What drives also, which a lot of individuals didn't realize, is the recovery audit contractors, those vendors, they get paid per the percentage that they find. So they're paid to find as much and to bring in as much as they can as recovery money. So that there's a pro and a con to that type of incentive. So would one speculate that maybe that's why it's swinging so much to the edge? Who knows? But a lot of us believe that there needs to be a relook and a review of how that regulation was written, since it's allowing for such a large swing to the other side.
Right, right. It sounds like something that, again, one needs to be knowledgeable about and ask the question if you are in that situation, so you know what you are getting into. And maybe the negotiation, I'm just thinking about this as we're talking, would be if you find out that you're on observation status, you either ask to be admitted or you ask if you could go home. So
Exactly.
you don't have to confront all this.
Exactly, and we actually have those two on our tips. The first question is to always ask. The moment you end up in a hospital bed in a room, the first thing you need to ask is, have I been admitted or am I on observation status? And then you need to have the conversation with the medical team that is bringing you to the floor to say, do I really need to be here, or can I be discharged and have these services done at home as an outpatient? Because even though you'll have those co-pays, it'll still be a lot less than having it done in the hospital under observation status.
Because you're getting charged both for the room rate.
The room, the board, right? You have all that going on too.
Right, as well as the tests and any other treatments that you may be getting.
Right, and when you're getting charged for the drugs, you're getting charged for the drugs the way they, because they're the ones giving you the drugs. It changes the whole pricing scheme when you're in the hospital and having to pay it that way versus just managing from home as you would have any other tests or office visits or consults that you need to do. The other thing we also say for people to consider, though, we always preface that, we never want anyone to negate using 911 for the usual chest pain, shortness of breath, profuse bleeding, but you'd be surprised how often going to an urgent care center sometimes is the better alternative. You have the cold, the flu, a sore throat, you think you sprained your ankle. Many things can actually be taken care of at an urgent care center, and then you're not put in that position of, worrying about, am I going to be in an under observation status because they're not sure what to do with me. Then if you go to an urgent care center and they tell you to go to the ER, then at least you've been sent to the ER under doctor's recommendation, and that might be able to help, not always. But people do need to think, patients do need to stop and think about what's best for them and what are the right questions to ask.
Right. I would think, though, also that this ties into healthcare reform from another angle. With having insurance coverage now for everyone, wouldn't people be incentivized, this is the whole idea, to go to their primary care office and be treated for most things there, or as you say, an urgent care center, because they will have some coverage rather than going for basic things to the emergency room?
I think for some it will work out well. I think the complexity will be for those who are on Medicaid through the healthcare reform, because some individuals, when they're going through the exchange, they're finding that they're eligible for Medicaid. Those who end up being eligible for Medicaid, it gets a little tricky then because of the way the co-payment system works and how some of them have learned that sometimes going to the ER is cheaper, which isn't necessarily right for it doesn't work well for everybody else. So that there's a little bit of complexity with Medicaid, but other than that, you would hope now that individuals would be able to see their physician versus running to the ER. It will be a behavioral change. If you've been going to the ER for years and all of a sudden you have to remember that I'm going to call a physician and see if I can make an appointment, and I'm just so used to being treated, I don't want to wait 2 days or I don't want to wait a day, so I think I'll just run because it always worked before. So we do have an uphill climb with the behavior change. Yeah.
That's a very good point that Linda just made, and that is with healthcare reform and again, knowing yourself and knowing what works for you, it's best to think these things through before you're in the experience. So based on this conversation today, you may want to think about, if I had a basic illness, again, not chest pain, profuse bleeding, etc., something that's very dramatic, yes, you definitely want to go to the emergency room. But anything short of that, you may want to think of what the other alternatives are, because you don't want to find yourself in this financial catch-22 and clinical as well as financial catch-22 of being in this observation status. And the hospital is again caught in the same experience because they don't want to lose money based on admitting you. So everyone's erring on the side of caution, except it's the consumer that's paying the price from that. From what you're explaining to us, it seems like they're the ones that are really carrying this burden.
Right, exactly, because it's either with higher co-pays when they go home, or if they have to go to a skilled nursing or rehab, they're then footing the full cost of that. Exactly.
Right. If you were a czar in Washington, because you have a degree in healthcare policy, what would be your recommendations to the people that are attempting to crack down on some of the abuse? But this is an unfortunate consequence, perhaps an unintended consequence of that action. So now that really needs to be remedied, what would be your advice?
I would think, number one, getting rid of the 3-day rule completely, I think, would make a huge change right there.
The 3-day rule?
The 3-day rule of where you need to be inpatient for 3 days before you can have your skilled nursing or rehab benefit. That would definitely help out a lot. From the RAC review and the fraud and abuse perspective, because we do know there is some out there, with the advent now of electronic health records, there are also systems out there that track fraud and abuse. And I think before you just start maybe paying these vendors to go in to get money based on what they find, and maybe they're doing this, I don't know, but there are systems out there that can track and trend now. And I think we might need to start doing a little bit more research on getting the statistics on what is really appropriate and what's not, almost from the guidelines perspective that we had on a previous show of let's take a look and let's see. How, when someone shows up with issues with COPD or congestive heart failure, how long is the average patient really in the hospital? Let's get a sense of because you could take all of that data and drop it into these phenomenal databases out there now that track fraud and abuse. CMS has one themselves that they use.
Would this data system be installed inside of a hospital that would be doing concurrent review?
They could either do that, they could either look at it to see if they could do the review themselves in the hospital, or maybe that's a piece that I just get really concerned when you have vendors out there who sort of just get paid for everything that they can find. You could really find a lot. You can really go crazy with finding a lot if you know that's what you're going to get paid for. I just think there needs to be some semblance of sanity behind it. I think we need to put some restrictions behind it, and I think we need to start really tracking some data and getting a good sense of the data, of what's really happening out there. I think that would tell us a lot, because there's systems out there that can track all of that, both externally from an insurer perspective and internally from a hospital system perspective.
Right. So when you see some of these reports about how some of the government reviews have brought up some fraud and abuse and how many millions of dollars have been returned to the government, maybe some of the fine print is that some of these reviews that were done were part of that puzzle and is not as fraudulent and abusive as that we might think on face value. It's just, again, looking for something so diligently, you're going to find it at every turn.
Exactly. And what research also finds is if the hospital goes back and appeals, many times they get the money back. But look at all the work.
Right.
Look at all the rework, because now they have to go file an appeal to then prove the case, to then get the money back.
Right.
So then you have individuals that are hoping, once again, that you don't do a lot of appeals.
Right. Well, Linda, in summary, I'd just like to thank Linda for her astute analysis of this topic, because in her practice, she does get called to help sort some of this out, particularly when people get these very high bills that they didn't even know that they were on observation status to begin with. She is often brought in, or her team members are brought in, to really see if there is any appeal to just those expenses, which is another very complicated administrative process. All of this we hope to bypass if we're ever in that situation. So I think that looking for alternatives before you wind up at an emergency room is the first thing to do. The second is to be knowledgeable if you have been admitted or not admitted, to know the consequences and to maybe put some limits or ask if there can be some limits that are reasonable. And so if you can go home and be treated at home, I know that there are some organizations that are looking at alternatives, some visiting nurse associations that are sending staff out where they can observe you at home for a whole lot less cost and be sure that you're okay. So to be forewarned is to be forearmed. And I hope that this really will help you understand not only the complexity of the healthcare system, because it is complicated, but how you can sort of migrate through that complexity and come out on the other side knowing much more, being able to take care of yourself better, and with this kind of knowledge, be able to bypass unexpected costs that you really didn't need to spend money on this anyway. So thank you again, Linda, for being our guest. I've learned again so much from you and from your experience. I really appreciate it. And I want to thank all of our listeners for being with us. Thank you so much and have a wonderful day. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening and join us again. And remember, with health, all things are possible.